Hi, everybody. My name is Dr. Madalene Rutherford. I'm very excited to share with you today. We're going to talk about trauma responsiveness and how occupational therapy practitioners can be trauma responsive for people that we support. By the end of this presentation, it is my hope that we can recall characteristics of the occupational therapy profession in mental health, state the ways that trauma changes the brain and the central nervous system, and identify evaluation and intervention areas that occupational therapists can support for people who have experienced trauma. What is occupational therapy? We know that our profession is individualized, client-centered, and it is holistic. So OTs and CODAs help people of all ages participate in meaningful activities through therapeutic use of everyday skills. And so as therapists, we specialize in the complex relationship between the person, the type of activity, and the environmental demands. We also know that occupations can be anything that is meaningful for the people that we support, and it often is centered around the types of activities that are expected of a person in a certain type of environment. So it can be things like cooking, dressing, bathing, medication management, play, school activities, driving, work, caring for others, or caring for pets. And as therapists who are holistic, we understand that the way somebody's brain and mental health is operating influences how we participate and we interface with our everyday occupations. We know that whenever we're providing occupational therapy services, we're using standardized and also non-standardized assessment tools such as client report, caregiver or family report, perhaps teacher report, in order to gather information about how somebody's participating in their activities. And from there, we proceed to the intervention, reevaluation, and hopefully discharge of services. We know that we have certain educational background in mental health as occupational therapists. So depending on when you graduated from occupational therapy school, it is part of the ACOTE standards to have about 50% of your educational training in mental health. So we are analyzing the effects of disease processes, including heritable diseases, genetic conditions, mental illness, disability, and trauma on occupational performance. When I was in occupational therapy school, one of my level 2 fieldwork experiences had to be in a mental health facility. So it depends on what services are available in your area. I was fortunate enough to have been placed in a true acute care mental health inpatient facility inside of a hospital, and I really enjoyed that placement. That's part of how I became interested in this topic as an occupational therapist. And then also, if we can think back to the time when we took our MBCOT exam, many of the content to prepare for the exam and questions on the actual exam focused on mental health as well. Not a lot of other professionals understand that we are versed in mental health, and so it's important that we share that and we advocate for our participation in this setting. We know that OTs can see patients in outpatient hospitals, home health, mental health, schools, and early intervention facilities. And we also know that people of all ages have mental health, and many of those people have experienced trauma, which impacts their occupations. We also know that the field of occupational therapy was founded on mental health. Many people forget this because we are currently operating in a primarily physical disability rehab system. However, our profession truly emerged in World War I. We were known as rehabilitation, reconstruction aides during that time, and we were helping combat veterans who were shell-shocked. So it was called shell shock at the time. However, now we know that they were experiencing post-traumatic stress symptoms, and we were employed by the United States Department of War, and we were focusing on crafts and vocational skills to help the veterans use their hands again and feel a sense of purpose and have activity happening in their everyday lives after the war. So we're talking about trauma, mental health. We know now, fast forward to the current situation, the current system that we work in as therapists, We know now that trauma does change the brain and the central nervous system of people that we support. In the typical brain development of somebody who has not experienced trauma, as you can see on the left, a small portion of their neurodevelopment, their brain energy, is going towards survival skills, and that is the way that we want it. So that means that more of their brain activity, their neural activity, is going toward higher level functional skills such as self-regulation, social emotional skills, and cognition. However, if you look at the brain and the central nervous system activity of somebody who's experienced developmental trauma, you can see a large portion of their neural activity, shown on the right, is devoted toward survival processes in the brain. That means that their brain is not devoting significant neural activity, neural energy toward regulation skills, social emotional skills, or cognition. So that we will see occupational skill deficits, occupational performance deficits in those areas. Every person, whether they've had trauma or not, has a hypothalamic pituitary adrenal axis, also known as the HPA axis. And this axis is a system in the brain that gives rise to our stress response as humans. It gives rise to our stress response to stimuli that are or feel threatening in our environments. They could be threatening in real time, or they could have the perception of threat. And so in somebody who has not experienced trauma, this HPA axis functions typically. It releases neurohormones to produce a fight or flight response during objectively appropriate and stressful times. Think, you're in a car accident, you have a huge exam coming up, you might have had a significant loss or death in your family. However, if you have experienced trauma in your past, this HPA axis releases these neurohormones and gives rise to the stress response irregularly. The stress response and this cascade of neural events are happening often, and that means that that central nervous system of the person is in a fight or flight response very often, and it's very hard for somebody in fight or flight to have strong occupational performance. This HPA axis does give rise to the fight, flight, freeze, or fawn response. So for short, we call it fight or flight. However, we know that there's also freeze and fawn. So the fight response behaviorally looks like somebody punching, hitting, kicking, acting out. The behavior is very externalized. It's very easy to spot. The flight response is somebody eloping, isolating themselves, shutting down. The freeze response is somebody shutting down almost in a sense that they're physically present, but they're spaced out. They're not mentally present. They might be hard to arouse or to garner their attention. And then the fawn response is only recently shown in psychology textbooks. I never learned about the fawn response when I was in undergrad school. The fawn response is basically a people-pleasing response, which this one is tricky in real practice to work through. This means that if you are presented with a threat, you start to people please, you start to be overly compliant, follow directions of people around you, and this is a really socially acceptable behavior, especially if you're thinking about children who have experienced trauma, and it can be really hard to detect this type of trauma response in people that we support, but it is a trauma response. It's also important to know that while you can transition between types of trauma responses, more often than not, people have a dominant type of behavioral response when they're responding to trauma. There are some behavioral signs that can indicate trauma. It's also important to note that if you see one or even several of these signs, it does not automatically mean that there is trauma. It's just raising a red flag that there may be trauma. Also, if you see any of these in isolation, again, it does not automatically signify trauma. Some behavioral signs of trauma can include frequent fear, frequent crying or tearfulness, regressive behavior, particularly in children, You might see bedwetting. You might see sudden baby talk. You might see almost like a type of learned helplessness for children, worrying about safety, being very easily startled or on edge, changes in sleeping patterns, or having difficulty falling asleep. Young children who have strong verbal and visual motor skills, they might reenact trauma during pretend play. They might draw photographs that depict trauma. Changes in weight loss or weight gain can be a response to trauma. Changes in eating habits can also signify trauma. Some people will begin to overeat in response to trauma. Some will start to undereat. And then something else that we see in children often is repetitive eating of similar foods. Sometimes you might find somebody who only likes a few foods. And we do see this in pediatrics with picky eaters. Maybe they had a larger food repertoire and then suddenly they're only intaking 5 foods. That can be a flag. Sadness, low frustration tolerance, showing risk-taking or reckless behavior, overly sexualized behavior, especially in older children, teens, or older adults. Cutting, aggressive outbursts, and dissociation or spacing out, not being mentally present. To talk about trauma, we also need to talk about post-traumatic stress disorder, or PTSD. Most of us have heard of PTSD in the context of combat veterans. It is true that many veterans who have been in combat do have post-traumatic stress disorder. However, veterans in combat are not the only population that experiences post-traumatic stress disorder. So many children who have grown up in chaotic or poor living conditions struggle with post-traumatic stress disorder. It is a mental health condition. It's characterized by seeing or experiencing traumatic events such as flashbacks, nightmares, anxiety, or dissociation, or shutting down. And unfortunately, this can cause suicidal ideation or suicide. For the purpose of tonight's presentation, we also need to discuss sensory processing disorder. As therapists, many of us are familiar with sensory processing disorder. Sensory processing disorder is whenever the sensory system of the central nervous system is intaking or interpreting sensory stimuli from the environment and struggling to produce an adaptive behavioral response that is appropriate. There has been a link found in research between post-traumatic stress disorder and sensory processing disorder. This link is not commonly known by occupational therapy practitioners, and it's also not commonly known by many mental health practitioners. So it's important as therapists that we help to advocate and bridge that gap and teach professionals in our practice settings that this is something that people who have been through trauma can experience. A study of the sensory profiles of adults with post-traumatic stress disorder showed polarizing variations between sensory sensitivity, sensory avoidance, and low registration patterns. So there are sensory processing disorder differences in this population. Sensory sensitivity in this particular research sample was whenever a small amount of environmental stimuli triggers a very large behavioral response. So we're thinking, you hear a small sound in your environment and suddenly we can't concentrate anymore, or perhaps we're having a very large behavior in the classroom and we're no longer attending to tasks. Sensory avoidance is when sensory stimuli can be overwhelming and we may begin to seclude ourselves or shut down. Today, I worked with a student. I'm a pediatric occupational therapist. I worked with a student who began to show sensory avoidance. He already wears headphones in the classroom, and then 3 of his classmates started becoming dysregulated themselves and screaming and carrying on. And he started crying, started shutting down, and walked himself to the opposite corner of the room and sat. That's sensory avoidance. Low registration is whenever a large amount of sensory stimuli triggers a very small or no behavioral response. One way that I like to think about this one is in context of pain tolerance. So I've had students in the past that I've worked with who can run full force into a wall, bounce off of that wall, fall onto the ground, and then look happy afterward or energized. And you think, aren't they in pain? What's wrong with them? They're not in pain. They have a low registration for the sensory sensation of pain. Similarly, some people who choose to cut whenever they've experienced trauma, in addition to struggling with emotional pain, they may not feel a significant amount of physical pain unless they cut. And so it speaks to the low registration patterns that people with trauma can have. On the topic of post-traumatic stress disorder, it's also important to note, as OTs, we do not diagnose anybody with anything. And it's also important to note that it's very rare that we will have a student or a young person that has a true bona fide PTSD diagnosis. It's not commonly given out to young children by psychologists or psychiatrists. However, we can gather information based on demographics and our interpersonal skills, getting to know people about their background and their trauma. During this presentation, this research that I'm sharing did involve children who had a bona fide post-traumatic stress disorder diagnosis. In another research study of children with and without post-traumatic stress disorder, it was found that there were sensory processing deficits in the children who had post-traumatic stress disorder. So again, we can be thinking with our therapy hats, okay, this is a difference that may exist if we know that a child has been exposed to trauma in the past or even currently. Likewise, a study of preschool children with poor or no housing showcased a positive correlation between sensory processing, behavioral difficulties, and housing instability. So not only does trauma affect sensory processing, but also having insufficient or chaotic living environments, even if you have a very loving, supportive family, that can trigger sensory processing disorder symptoms in young children. What do we do about this? We are therapists. We are here because we want to help people heal, and we want to help people perform and function in their occupations. We can assess for sensory processing differences in students, young adults, older adults who have experienced trauma. We can use the short sensory profile, the sensory processing measure, our own clinical reasoning, as well as client report, caregiver, family, or peer report. Whenever we're thinking about interventions for sensory processing, we'll look at the results from the assessment tool that we used. And the entire idea of the sensory processing interventions is to help the brain of the person transition from operating at caveman level. So we know that whenever we're dysregulated and we're in fight or flight mode, most of the neural activity in the brain is coming from the lower parts of the brain, such as the brain stem, the midbrain, and the basal brain. We want to try to increase activity in the entire brain because we know that that's where most of our functional, cognitive, social, and regulation activity occurs. So we can create sensory diets, sensory strategies to help regulate the person. Ideally, we would create preventative sensory diets based on the results of our sensory assessments, and then embed those strategies within somebody's daily routine in order to prevent behavioral meltdowns. Now, I work with young kids. You can have the best plan in the world. You can have the most strategies in place in the world. And it's very hard to stay ahead of somebody's dysregulation because we can't control every factor in somebody's day. So sensory interventions can also be used as a reactionary way or a way to respond to somebody's behavioral dysregulation. The only thing we need to remember, especially when we're working with young kids, I find with adults it's a little bit less imperative to think about it this way because adults have more autonomy in how they choose to live their lives at the end of the day. Children are still learning, how to listen and follow directions. We want to be careful that we're not rewarding negative behavior with a sensory strategy after a meltdown. So my recommendation for using sensory strategies with your so-called behavioral kids in the school system or in an outpatient setting is, if we have to use it after they've already had a meltdown, that's fine. Get them calm, get them regulated, and then they need to return to whatever demand was in place before they had the meltdown, in case the meltdown was just to avoid a demand, or in case that was a large part of the meltdown. We can also modify the environment to help sensory processing interventions. We can change the lighting and the visual stimulation. We can incorporate music or auditory items. Deep pressure devices can be helpful. Vestibular seeking devices can be helpful. Fidgets, olfactory items. So we can be using essential oils, and then gustatory items, or our sense of taste that can be incorporated as well. We can incorporate these into somebody's classroom, their bedroom, home environment, outpatient setting, our hospital room, wherever we're treating the patient. Or in a school setting, it can be very interesting to create a calm down center or a site, a physical room that's used as a center of regulation or co-regulation. We can also look at the person with trauma's attachment system when we're creating interventions to help them. It's important to note that as occupational therapists, we will never diagnose somebody's attachment needs. We do work closely with the people we support, and oftentimes by interfacing with them consistently, we can ballpark the type of attachment that they have. So attachment refers to how we relate to people in relationships as adults or children. Now, especially if you work with young children, you will see that somebody's attachment really has a lot to do with how they're going to interface with you. If you think about in the school system, the so-called behavioral kids, many of their behaviors has a lot to do with their attachment system and how they relate to adults and authority and caregivers. There's anxious attachment, which is whenever you're very overly attached to somebody and you can struggle with a sense of your own independence and also that other person's independence. Avoidant attachment is whenever you struggle to feel okay with a sense of closeness with somebody, and you might really prefer your emotional distance to that person. Secure attachment is not common in people with trauma. The first two are. However, secure attachment is whenever you're pretty equally comfortable with a sense of closeness or separateness emotionally in a relationship. And then mixed attachment, many people with trauma do have mixed attachment, and that's whenever they might swing on a pendulum between anxious and avoidant attachment. So it's this sense of come here, no, go away. I want you here with me. I don't want you here anymore. I want to follow directions with you. I don't care what you say. And it might look like it's in behaviors with students, for example. It might look like, oh, I don't want to participate in this demand that you place on me. However, it could just be an attachment wound flaring up, and it might be about the person placing the demand. Whenever we are providing therapy, we are trying to create a strong and consistent and therapeutic relationship with the people that we support. Many of our activities inherently build a relationship with the people we support, and our goal with attachment-based interventions should be to help regulate that fight or flight system, that stress response, to a calm and neutral state so that the person can use as much of their brain power, their neural activity as possible for higher level occupational performance. Now, I work with young kids, So whenever I'm doing this with somebody, I am trying to incorporate physical touch into my interventions as long as they're comfortable with it. I have a few children that are very upfront that do not like touch. Do not touch a kid with trauma if they don't like to be touched. So counterintuitive. Parallel play, that can help with attachment. Joint or together play really helps with attachment. Having a strong sense of eye contact and a positive expression on your face really helps to build that attachment system. Verbalizing positive feelings about the student or the person that you're supporting can help. For example, I love it whenever you and I spend time together. I'm so happy that you came to see me today. I'm so happy to hear about XYZ. I'm so happy that we can play this game together. I'm so happy that we can we can learn XYZ together. Now, especially when you're working with young children as well, having clear, consistent, and firm boundaries is also important in the therapeutic relationship. Many times, kids in general like to push boundaries, and then people with trauma might like to push boundaries even firmer. So while we do want to validate and be empathetic to somebody's emotional experiences and their trauma, we still need to set a boundary with them to learn to follow directions and create a sense of safety between the therapist and the person. We can also assess something called co-regulation when we're supporting people with trauma. Co-regulation is a person's ability to regulate their emotions in the presence of somebody else. This is a developmental skill that every person goes through, and ideally, they will develop the ability to self-regulate, regulate without the input of another person. However, many people with trauma, many people with autism, many people with developmental delays, special needs, have delays in this area of co-regulation, and so it can be very difficult for them to calm or manage their emotions without an adult helping them. The best ways to assess co-regulation, the way that I was taught co-regulation, is that it's a combination of sensory processing and the physiological and behavioral responses of the person. So we can assess with the short sensory profile, sensory processing measure, and for this it's very important to use our observational and clinical reasoning skills to look at signs of stress, signs of excitement, signs of fear, signs of depression, signs of excitedness in the person we're supporting in the moment. It's also important, especially if we're working with people who have strong verbal abilities, ask them how they're feeling. Especially in the school system, sometimes we work with students who have no verbal abilities. Maybe they use an AAC device and maybe their emotional language is very limited. On the other hand, I support many students who have had significant trauma that'll tell you plain and simple, I'm feeling stressed today. My back hurts today. My shoulders are tense. I feel fearful often. I'm worried often. I feel so stressed at home. And they do have the emotional language to share this with you. Whenever we're intervening for co-regulation, we are creating a combination between sensory interventions and attachment interventions. So another way to think about co-regulation is, if anybody here has ever seen a baby that needs soothed or had a baby that needs soothed, we know that a baby typically can't calm itself down by itself. I mean, you can try that strategy of letting the kid alone forever when they stop crying. It's not good for their attachment system. Whenever you have an infant, you know, typically the mother or the father needs to pick up the baby, hold them, soothe them, and what helps the baby calm down is sometimes it's the rocking, the swaying, the swaddling, and the sense of presence with a caregiver who's consistent and cares about them. That is co-regulation in infancy. Now, people who have typical emotional development will develop the ability to self-regulate eventually. People with trauma have not gotten that yet because they have had broken relationships with caregivers or people in their household or people in their environment. So, do we need to pick up students in the school system and hold them and rock them like a baby? No, but something I do with students who need soothed or need co-regulated, I'll hold their hands. Maybe we'll rock, maybe we'll sway, maybe we'll have a long hug, and then we're trying to get our central nervous systems to tune into each other. Ideally, we're trying to get the child's central nervous system to share my calm energy. If you've ever worked with a young toddler or a baby and you've been stressed out or feeling chaotic internally yourself, you know that it's a lot harder for that baby or toddler to calm down. But if we're in a calm emotional state ourselves, it becomes much quicker and a simpler process for that young person to calm down. It's the same for people with trauma. We're trying to help that HPA axis response and central nervous system neutralize in order to feel a sense of safety and calmness, because we know safety is a precursor to optimal learning and optimal occupational participation. We can also assess interoceptive awareness for people who've experienced trauma. Interoceptive awareness refers to the body's ability to perceive internal and external physiological states. So this can include internal sensations such as sexual arousal, thirst, hunger, needing to urinate, needing to defecate. It also refers to our emotions, or understanding of our emotions. And then on the outside of our bodies, it refers to our awareness of how sensations feel. There is an assessment called the interoceptive curriculum. I am biased. I was taught in college by the professor who created this curriculum. However, if you've ever looked at it, you know it's amazing. I recommend it. It's also very inexpensive, by Dr. Kelly Mahler, who I referenced in this slide. We can also use our clinical reasoning skills and look at the physiological and behavioral responses of calm versus chaos in the person. And again, if the person has strong verbal abilities, we can ask them about their interoceptive awareness. So when I'm talking about interoceptive awareness, you might think, oh, that sounds a lot like mindfulness. The two concepts are similar, however, they're not the same. So mindfulness, people with trauma cannot participate in mindfulness very easily. That skill of mindfulness, of tuning into your entire body and what it feels, that skill can be very high developmentally for many people with trauma. So that needs broken down into more concrete, smaller examples for people with trauma. Interestingly, research also shows that other people with other types of disabilities also have interoceptive awareness deficits. People with autism, ADHD, different developmental delays, excuse me, different mental health diagnoses do struggle with interoceptive awareness. There is a developmental progression for the sense of interoceptive awareness. Whenever we're trying to help somebody develop their interoceptive awareness, we are trying to teach somebody to identify their body sensations, and the developmental progression of this starts with external body parts because they are concrete. So for example, rather than me saying, my body feels calm right now, a person with trauma might not even understand what that feels like for them because that is too broad. So to teach this developmental skill, we may focus on one body part, the forearm, external body part, the forearm. And we may try to really target different sensations in that body part. So, when I rub my forearm, I feel calm. When I pinch my forearm, I feel pain. When I pull the hair on my forearm, I feel pain. And putting strong verbal meanings to those sensations helps to develop that sense of interoceptive awareness. The verbal piece is important because, like any other skill, it needs modeled, it needs taught. So many people with trauma have not grown up in environments where emotions were processed significantly or emotional language was developed. As a result, many people with trauma struggle with being in tune with their emotions, and even if they are in tune with their emotions, to describe what they're feeling or what they need can be difficult. We also know in order to make a plan to help yourself when you're in need, we need to know what we're feeling first. There is research that has been conducted that shows that people with trauma and different mental health diagnoses can list different coping skills that they've been taught to use when they are in need. So you can ask somebody, oh, what are your coping skills? They'll say, oh, I can go on a walk, I can do yoga, I can journal, I can exercise, I can call my mom. However, especially in my experience in the inpatient mental health setting, you do find there's a gap between folks who can verbalize those coping skills and them applying them in real time when they're in crisis or when they're having a hard time. What's the gap? The research shows that the gap is their sense of interoceptive awareness, their sense of ability to understand in real time, hey, I have a problem. This is what I'm feeling right now. Therefore, I need to apply a coping skill to use. As such, without a strong sense of interoceptive awareness in the body, a sense of coping skills, a set of coping skills becomes an empty arsenal that somebody with trauma carries with them and cannot use in real time. Interoceptive awareness is developed strongly in the neural center in the brain called the insula. It's a two-piece part in the brain, the green in the photo. And this does help us develop the blueprint for knowing when to use coping skills. The takeaway from this slide is if you're working with people with mental health needs or people with trauma and you're teaching them coping skills and they are not applying those in real time, that means that we're missing a step in the process, that them giving them the coping skills without the skills to use them is too high, and that's why they're failing. When I was in the inpatient psych unit, that was very hard for me to watch. And this is a very hard lifelong process that people develop this with trauma and people without trauma. But it's very difficult to see frequent flyers in mental health settings struggle without this skill. As OTs, we can also support and assess somebody's daily routines. Our daily routines vary based on our practice setting and the age of the people that we support. I previously worked in a preschool setting, so to examine daily routines, I used the Pediatric Evaluation of Disabilities Inventory for self-care skills. I also used the Peabody Developmental Motor Scale, which looked at fine motor skill expectations for young children. I'm currently in a K-12 school-based practice setting in Pennsylvania in the United States. We're looking at occupations such as handwriting, visual motor skills, matching for classroom activities, letter formation, also looking at school-based self-care skills, skills at lunchtime, feeding yourself, being able to open and close containers, clothing fasteners, using the bathroom, activities like that. We can also talk with people themselves and talk with their support system to learn more about their daily routines and their expectations in their day. We know that neurally, most of our higher level occupational activities occur in the prefrontal cortex and the somatosensory cortices of the brain. So these are the outermost parts of the brain. We also know that Executive functioning skills are very important for independence and success in life and in occupations. The important thing to note in this slide is that the ability to use executive functioning skills can be very difficult for people with trauma if they're living in a fight or flight stress response constantly. Therefore, activities like emotional control, impulse control, organization, task initiation, planning and prioritizing, self-awareness can be difficult for people with trauma. Also, we can help embed coping skills into the daily routines of people with trauma. However, we must remember implementing coping skills will be very difficult if they don't have the precursor skill of interoceptive awareness in their daily routine. But if we're trying to create a healthy daily routine for somebody, ideally we would embed some coping skills or some sensory strategies into that routine to help them function and participate. We can teach healthy habits, routines, and rituals, and we can also teach energy conservation techniques into the daily routine, as well as those sensory regulation or attachment strategies that we discussed. And then if we can get somebody consistently regulated, then we can also address executive functioning skills for planning, mental health recovery management, medication management, community mobility, workplace demands. And something that's important on this slide also, if we talk about medication management, many folks with a history of trauma will use psychotropic medication at some point from their doctor. Medication management independently can be difficult for people with trauma if they're in a fight or flight response. So it's a chicken or the egg situation. We need them to take medicine to be okay. However, we also need them to be okay enough to manage their ability to consistently take the medicine. So all of these skills are intertwined, and it's very important that we get the brain regulated at the lower levels so that the person can use all parts of their brain in order to participate in meaningful occupations. We can also assess sleep hygiene assessments. I primarily use clinical reasoning for this. There are non-standardized forms that you can use in order to assess sleep hygiene. This is in the area of wellness or occupational wellness. If we're talking about children, we can ask questions such as, does the child fall asleep easily? Do they stay asleep? Do they self-soothe if they wake up, or do they soothe with a caregiver? Does the family co-sleep, or is independent sleeping important to them? Some families in different cultures prefer co-sleeping. That's okay. That's their ritual. What are the sensory characteristics of the sleep environment? What does our bedtime routine look like? What does evening wind down routine look like? Does the child spend time during the day burning off their energy? Do they have a chance to play frequently? Do they sit on a device all day and struggle to wind down at night? Are they outside during the day? There is research that links that exposure to the sun helps regulate circadian rhythms for optimal sleep. If we're working with older teenagers or older adults, some of these same questions apply. Device use is a significant question. Some people use their devices in order to wind down. Other people have a hard time winding down because of their devices. Similarly, if we're talking about older teens or older adults, do they use any stimulant drugs that might prevent them from sleeping and resting? Are they using nicotine, which can be stimulating? Are they drinking caffeine? Are they using any other types of drugs that make them stay awake? While we know that it's counterintuitive, many people may have to change their substance patterns in order to have stronger sleep hygiene. And we know that sleep hygiene is very important for self-regulation and mental wellness. I know myself, if I have had a hard night's sleep or struggled to get sleep the night before, the next day I'm definitely irritable and grumpy at best. If anybody here has ever had a newborn and you're not sleeping consistently, you know that that lack of sleep really does change how your brain processes information, how you feel. And many people with trauma have lifelong sleep difficulties, so it's important that we try to assess and intervene in this area. I look at our role in this area of practice as consultative. I've never provided an intervention where I'm watching somebody sleep and talking to them about how to better their sleep. We can talk about it with them or their caregivers if there are support system members. I like to discuss consistent sleep-wake times and a calming wind-down routine, sensory regulation strategies before bed. Again, understanding that each person has distinct sensory needs based on our sensory assessment that we've already done. Weighted blankets have been shown to be helpful for many adults and children for sleep hygiene. Modifying the bedtime environment with lower lighting levels, soothing sounds or no sounds, removing devices if that's important for the person. The temperature in the house can also influence sleep hygiene. Lower temperatures tend to evoke a sense of calm before bed rather than hot temperatures. Trying to stay consistent with a sleep-wake cycle is very important to discuss, and it does sound very self-evident, but some folks really struggle with this. They might sleep in until noon one day, and then it's, 10 p.m. later that night, and they're thinking, why am I not tired yet? Not tired because your body's still awake. It's primed to be awake. We can talk about independent sleep strategies if that's important to the family. Different strategies to provoke self-soothing. We can talk about co-regulating strategies if co-sleeping is important for the family. Strategies for insomnia can be discussed, and again, limiting the use of stimulants throughout the day can be helpful for people who have had trauma. Those are some of the preliminary areas we can help support for people who've experienced trauma and some of the areas that we can assess and intervene. Thank you all for participating with me tonight, and I would be so happy to hear any questions, comments, or stories that anybody has.
All right, let's get to some of these questions now. Drug use and damage to the hypothalamus that affects trauma response, question mark. Let's see if I can get a little bit more info. Yeah, so we just, so it just says drug use and damage to the hypothalamus that affects the thalamus. So Rosemary, maybe if you could throw in a little bit more descriptor there so we can kind of know where. Okay. Oh, okay. Have you come across this? Okay, so thanks, Rosemary. So have you come across this, that drug use and damage to hypothalamus that affects trauma response?
I mean, I've worked with young children who have had abstinence syndrome from maternal drug use, and it can prime their central nervous system to be dysregulated. Those students that I've had have really struggled to find a sense of calm just on a regular good day, and their sensory systems are very picky, so to speak, and very finicky. Am I getting at what you're asking in your question?
She says, thank you. Yes. Also, have you come across hypothalamic syndrome?
It's not something that I've ever heard of, but I'm curious to learn more.
Okay, great. All right, so let's see if we have, so Rosemary says, thanks. All right, and another question coming in. What is your experience with relaying trauma-informed information to parents, especially for those kids that are labeled as bad?
That is a good question. That's a tricky conversation. If we're talking about a child who has adopted parents and the adopted parents have provided a nurturing and consistent environment for them, I definitely talk about it right away because I'm not going to offend them. They know that this child has trauma and it's not from them, so they're not in a defensive posture at all about the kid's behavior. For that type of scenario, I'll just usually say, because of how he lived before he was with you, his brain and his body struggle with these things, and it's important for us to put in more effort to keep him calm and regulated and help him feel safe in order to hopefully improve his behavior at school or at home for you. Now, such is the case where I currently work. Many of our students, I'm smiling because it's true, not because it's happy. Many of our students do live in environments where their parents are traumatizing them, and you make abuse reports and nothing gets done, and that's the reality of it. For those students, I don't often have opportunity to interact with the parents very often because they're not very involved, which is sad. So try to do what I can in the school system and teaching teachers and paraprofessionals about how we can help to essentially nurture and co-regulate the student and be consistent in our relationship with them, as well as help to reframe behaviors that the student has. Now, I do have a handful of parents, like a small handful, where they do provide the chaotic environment for the student, and I do have a chance to interact with them. With that population, I try to, you have to remember who you're talking to. They are, if we think about trauma, we know trauma is generational, and so we know that we're not excusing anything that they've done, but we know that it's very likely if a parent or caregiver is traumatizing their child, they very likely grew up with a similar type of trauma and they are passing down what they know. Parents do the best they can and they do what they know. And so in those situations, I try to work with the defensiveness. They are very defensive, often very combative. And we just, we really want to praise what they are doing well, praise that, we love their child, we love spending time with them, just provide strategies as we're able. But I would never say to them, like, you're traumatizing your child. Also, I mean, some of those folks have already had like CYS called on them. So they kind of have an idea that somebody in the school system thinks that they are not doing what they're supposed to be doing anyways. So I don't really need to say it out loud to them, if that makes sense.
All right. Do you tend to apply trauma-informed practice approaches to general groups of students versus specific students that have a history of trauma?
Well, that's a good question. In my practice right now, I don't do a lot of tiered interventions, but we are going to be starting tiered interventions in the spring, hopefully. And so I would like to provide it to entire groups of students, whether they need it or don't need it. When I teach this to teachers, I do try to teach it as an entire classroom intervention or entire group intervention, informally, I would say, because much of what we're recommending as far as like sensory goes or regulation goes, we can translate that to an entire group activity for a classroom. And in that sense, if we're talking about like a higher student with behavioral needs, it's not in like a special ed classroom, in that sense, we don't have to single out this kid with a behavioral problem and make it clear, like, okay, this kid's having a problem, so we got to do this for this kid. But if we make it a whole group thing and we make it very nonchalant, like strong relationships, movement breaks, affirmations, things like that, it really just becomes, okay, I am the teacher. This is how I teach my students because I want them to feel safe and I want them to learn.
Awesome. Okay. Which techniques or interventions have you found most successful in your sensory diets?
That's a good question. It does all depend what each individual student's sensory needs are. We're therapists, so we do know that sensory assessment results look different for every student. I do find that many students with trauma really like movement a lot, and the research supports that as well, what I focus on for my doctoral work. So I also found that yoga-based activities are very helpful for the students that I see, and the research strongly supports that too. So for my doctoral coursework, I did a scoping review of sensory interventions for people ages 3 to 21 with a history of trauma. And yoga-based interventions were not only the most commonly cited form of intervention in the research empirically, but also had the strongest efficacy in the results. My students love it. I also love it because I don't have to bring in intervention modality. Like I don't have to carry a bunch of things with me in order to do the yoga with them. We can just do it together. I'm a therapist that really likes to get on the ground and horse around with the kids when I pull them. And so it's something we do together. We're regulating ourselves, and it's versatile. So we can modify and we can adapt what we're doing in the moment to meet their needs. Other interventions that work, I do find a lot of them really like deep pressure, strong hugs, and also like low lighting, sense of calm lighting, and like a not busy sort of auditory or visual environment. They tend to respond to that pretty well.
Awesome. Okay. How do you determine the difference between sensory needs, which may be related to trauma responses, and behaviors?
That is a good question. How do we determine the difference between sensory needs and behaviors? I think in this population, that line is even more fine than it is regularly to begin with. So we know that people with trauma do have sensory needs, and we also know that people with trauma do have behaviors. When we're talking about behaviors of people with trauma and people in general, we need to think about what's the purpose or what's the function of the behavior. Behavior is a form of communication. When we have people with trauma acting out, why are they acting out? Yes, it can be very annoying. And I love my students to death, but yes, it can be very annoying when they are throwing a fit and they're acting out and they're acting just totally off the walls. But when I'm thinking about kids with trauma, try to remember if they're having some of those strong attention-seeking behaviors, acting out, protesting, misbehaving types of behaviors, they're likely doing it for attention from a caregiver, so a sense of an attachment need that's not being met. They also might be having an emotional problem that they don't know how to express in language, because we do know people with trauma struggle with interoceptive awareness. Many kids with trauma, what they've seen at home in terms of interoception modeling is, okay, I'm feeling something, I throw things, I hit people, I throw a fit in the house, and that's what they bring to school with them, right? And so it's not an excuse for what they're doing, but many of them have not learned another way to relate to themselves or other people. And so your question was, how do we determine the difference? I think it's important to try to be in tune with the students or the people we support and try to think about those areas that we talked about in the presentation and think, okay, is there something here that could be not being met that I can try to meet in the meantime? I hope I answered your question.
If not, yeah, we can send some more questions our way, but move on to the next question is, how do you feel about BCBA and students with trauma?
It's a good question. It's not my favorite, to be honest. I have my first job as an OT was in a very strong and strict behavioral setting. It was so strict that they did not believe sensory processing was even a thing that needed to be addressed at all. I had to advocate very strongly to get them to understand that sensory affected students, and also understand that, like, you cannot look at a student with special needs without thinking about things that are happening inside of the body and inside of the central nervous system. Um, what I don't like about behavioral or BCBA, the way that BCBAs are typically trained, is that they don't receive a ton of education about, they use the ABC approach, and the A stands for antecedent. They're trained to think that antecedents are only externalized behaviors. So if they're watching a student and there's no clearly defined externalized behavior happening, then they think that, or an antecedent, excuse me, to the behavior, they think that the kid's just acting out. When in reality, as OTs, we have a lot of education about what's happening inside the body, inside the brain. I think that they mean well. I think that they have very strong observational skills for externalized behaviors. I think it's important, if we're working with those professionals, to advocate and teach them that, okay, based on assessments especially, they like to see data. So if we can provide data from an assessment tool that says, this is how the person is wired with their central nervous system inside of their body, this is what they struggle with. I think that those professionals need education to understand that an antecedent to a behavior oftentimes is something that they cannot see. I think that trips them up. However, at the same time, we're all human. We all have emotions. I mean, I sit sometimes and I might feel sad, and somebody outside of me might think, oh, she's fine. Nothing's going on, you know, but inside, I know I'm feeling an emotion, and there is an antecedent to whatever I'm about to do that somebody might not have seen. If that makes sense.
Okay. Any tips with support on visually impaired students?
That's a good question. Are we talking about visually impaired students who have had trauma? Can we be more specific with the question?
Yeah, Jennifer, if you could just follow up with some yes with trauma. Thank you, Jennifer.
I can't say that I've had um, somebody with trauma who's also blind, but if they have a sense of hearing that's strong, I think it would be important to try to build trust and predictability through your words. We can work on, you know, sensory with words. We can work on building trust with words and communication. Also, a lot of interoceptive awareness is built through verbal language, being able to put language to your physiological experience through instruction and practice. And so I would try to focus on that. And I imagine if somebody was blind and they went through trauma, building trust and predictability would be even more important, not knowing what you cannot see. If that makes sense.